Hello, hello, and welcome to another chapter of Pediatric Primary Care. Today we're talking about Chapter 12 Developmental Management of Middle Childhood. Jumping right in, children in the middle childhood are busy, active, curious, and creative. With guidance and encouragement, they eagerly apply the skills they learned in early childhood as they move into structured school environments, homeschooling, or community setting. While each child is unique and typically development patterns have broad parameters, the developmental goals for this age group, 6 to 10 years old, include laying the groundwork for lifelong learning, creating a sense of self-worth, developing the ability to contribute to the world around them, and ultimately gaining satisfaction with life. Primary care providers must be familiar with physical, cognitive, social, and emotional development in order to provide high quality, comprehensive care for this age group. They support children's successful growth and development through obtaining appropriate health history details, conducting physical assessments, and providing anticipatory guidance and health promotion education. Developmental overlay. This section discusses the developmental context for the elements of a well-child preventative health visit. It introduces the physical, social, emotional, and cognitive tasks that are mastered during the typical middle child development, starting us off to the physical growth and development. Physical growth velocity in middle childhood is slower than infancy and early childhood. Prepubertal children gain an average of 2.4 to 2.8 inches and 6.5 to 7.5 pounds per year, with growth occurring discontinuously or in spurts several times per year. The occipital frontal, the head circumference, increases an inch or less and is no longer routinely measured. Physical growth and neurologic maturation give children the ability to master many new skills. The cerebral cortex and the frontal lobe are the last to fully develop. Increasing brain maturation allows children to complete increasingly complex motor and cognitive skills and to have greater body control. Visual acuity development is generally complete by 6 years of age. Table 12.1 gives an overview of the typical physical development during middle childhood. Body image and a sense of self begin to develop as young as age 5 to 6. Children this age are often curious about changes happening to them as they grow, and they are sensitive to others around them. Highly literal in their thinking, they can be very frank and question people they trust. Their achievements and failures help them define who they are and influence their evolving self-image. Social status among children is often based on physical competence. Therefore, the children's feelings about their physical development can be as important as their physical growth itself. Their body image comes from the experiences they have and feedback from family, peers, teachers, and others in the community. They are also sensitive to opinions they perceive from social media. When positive, this feedback helps clarify their self-understanding and allows the child to gain self-confidence and feelings of worth. However, negative messaging can have the opposite effect. Children in middle childhood often compare their bodies with their friends of the same sex. At the same time, they learn the importance of social politeness and may be uncomfortable or shy about new or unusual situations. During puberty, children may have mixed feelings ranging from curiosity and excitement to anxiety and shame about the physical changes occurring in their body. These feelings may be amplified for children who are gender nonconforming, as physical body changes may create discomfort or distress. Exploring of one's sexual organs, including masturbation, is common in this period. gross and fine motor development. Children in middle childhood gain strength and coordination, leading to more physical capabilities and setting the stage for sports and other physical activity participation. Their gross motor skills are refined, allowing them to run, jump, climb, hop, skip, tandem walk, alternate their foot patterns, and use an overhand motion. Activities that require balance and coordination demonstrate their expanding skills. Toward the end of middle childhood, gross motor skills are more controlled and purposeful and are perfected with practice. These children tend to be competitive as they try to outlast or outperform one another, and they often enjoy participating in competitive activities such as sports. Fine motor skills mastery include improved dexterity and better control of scissors and writing tools. Their drawings become more recognizable, showing eyes, ears, and other body part details. Technology is part of classroom daily life, and children progress in their mastery of digital devices. In early childhood, children become adept at dressing themselves, including being able to tie shoelaces and manage buttons and zippers, and self care skills improve. As they mature, hand eye coordination improves, and they are able to use each hand independently with speed and smoothness. As an example, skill playing musical instruments may start to emerge. So here's our first spot to hit pause. The physical development in middle school, or I'm sorry, childhood. Body systems and the developmental changes, whether it's the skin and lymph, the head, eyes, ears, nose, mouth, and neck, pulmonary, cardiovascular, GI, GU, musculoskeletal, or immune system. Social development. Children this age experience substantial psychosocial development, which including increasing independence from their home and family, establishing friendships, negotiating with siblings and other family members, and working on developing a sound sense of who they are as unique members of the community. The ability of children to form friendships depends on social cognitive development and is a direct result of parent-child relationships. During earlier development, as they increasingly interact within their community, children maintain their role and feelings of belonging within their family, but they also develop secondary attachments with adults outside the home. Having positive relationships with adults outside the home is especially important for children who come from families with dysfunction or conflict. For parents and primary care physicians, it is important in this age group to reinforce the recognition and avoidance of predatory adult behavior, both in person and through electronic media. It is important for children to have the opportunity to engage in social extracurricular activities to facilitate interaction skills development, including how to understand social meaning and interpret others' social cues. They learn to form and engage in relationships through the initiation, maintenance, and termination of peer interaction. Friends are generally chosen because of shared skills, interest, personality, and loyalty. Gaining social acceptance from peers depends on skills such as being socially responsive, understanding group rules and jargon, being appropriately assertive, and being empathetic. Children who do not have those skills can experience a sense of failure when they are compared with their peers who do. Children often view themselves through the eyes of their friends. They develop best friends and dress and talk like their peers. A special friend phase typically occurs around 10 years of age. With that friend, the child expands the self, learns altruism, shares feelings, and learns how to manage problems. Talking on the phone, texting, emailing, using social media, and having sleepovers with friends becomes more common. These early friendships are the basis for later relationships. Family conflicts arise when peer activities and expectations conflict with the family rules and values. Further, the values of the family are challenged as the child learns that the families make decisions and have beliefs that are different from their own. relationships are crucial to the biological and behavioral development. Adverse childhood experiences refer to events or experiences that negatively impact child health, particularly social, emotional, and cognitive development. ACEs are also predictive of negative health outcomes in adulthood. The landmark ACE study and subsequent research have affirmed that early identification of ACEs is critical so that the early intervention and support services can be initiated. ACEs include physical, verbal, or sexual abuse, household dysfunction such as domestic violence, household substance abuse, mental illness, and criminal activity. Additional ACEs have been suggested to include physical and emotional neglect, parental separation, bullying, and foster care. Which brings us to the emotional development. Assessment of emotional development is an important aspect of the well-child examination, as an estimated 16.5% of US children have at least one mental health disorder, whether it is attention deficit hyperactivity disorder and anxiety are the most common mental health disorders in the middle childhood. During this time, children gain the ability to self-regulate, control impulses, and manage emotions. By 7 years of age, children are typically competent, functioning in a variety of settings. Emotional problems during these years often follow frustrations, losses, and/or situations in which the child's self-esteem is threatened or the child is faced with adversity. At this age, children tend to be rigid in their views of right and wrong, which is consistent with concrete thinking. They understand the relationship between responsibility and privileges and realize choices between right and wrong behaviors are within their control. Some children are motivated to behave to get a direct reward, whereas others are motivated by their sense of duty, viewing moral behavior as following the rules of higher authority. The ability to reason through difficult situations with a variety of influencing factors is heavily dependent on the cognitive development. However, children this age do not have the cognitive maturity to cope with all situations. The school environment, where rules and values may differ from those of their family, must be confronted and negotiated daily. Social pressures, often from peers, may make it even more difficult to choose actions that the child believes are right. Temperament affects the way in which children interact with peers, teachers, family, and others in their environment. As part of the process of developing relationships with others, they refine their ability to identify, label, and manage their feelings. However, their experiences are limited and their cognitive abilities are still developing. Therefore, children's coping responses are largely dependent upon parent support and modeling, and they continue to need help labeling complex emotions, such as sadness, depression, worry, and envy. They also need to help manage feelings in acceptable ways. Maladaptive behaviors may occur when the child's coping responses are overwhelmed. Entry into school can be emotionally stressful because children must adjust to a new social situation, routine, and a changing relationship dynamic within their family. Some parents feel that they have lost their child, watching them move from dependence on the family to participation in a new world, of which they are not a part. Other parents anticipate these new opportunities facing their child and family and are ready to help the child cope with challenges that emerge in the school environment. Impulse control is an important coping skill for children to develop. Without impulse control, erratic behavior may occur. Conversely, overly controlled children may be perceived as hostile, uncreative, or both. ADHD and disruptive behavioral disorders may emerge during that time. Behavioral challenges may impact a child's school performance, and disruptive behavior often leads to a negative disciplinary consequence pattern that affects the child's self-esteem and motivation. Of note, children may face a variety of stressors within and outside of the home, including violence, bullying, divorce, family or peer group substance use or abuse, early responsibilities, and or a lack of support in school. Any stressor has the potential to adversely impact child development. Safety is a constant concern for many in neighborhoods where children live and play, and in their families and schools. Bringing us to cognitive development. In middle childhood, children transition from pre operational thinking to early concrete operational thinking. Magical thinking and egocentric logic are replaced by rule driven behaviors, including understanding the consequences of breaking rules. The concept of conservation, transformation, reversibility, decentration, seriation, and classification also start to emerge. Concrete operational abilities allow effective reading, writing, and thought communication. Learning about the world, people, and the views and values of others is possible. They can focus on more than one aspect of a problem and use logical thinking. New social skills appear with the ability to understand other viewpoints, and egocentricity disciplines and starts to decline. Empathy, the ability to share and understand another's feelings, emerges, which allows for added depth in peer and family relationships. Empathy also helps children negotiate complex situations, especially when disparity occurs. Cognitively, children in middle childhood face daunting challenges. They must master the intellectual skills of reading, writing, mathematics, science, and other academic work. They progress from learning to read to reading to learn. Those who fall behind in reading or do not master early reading skills tend to struggle as they face increasing challenges and expectations for reading comprehension. Performance expectations increase progressing from homework and quizzes to examinations, graded papers, and projects. Many schools lack the resources to maintain small class sizes or offer special programs for children who have learning difficulties, which increases the risk of children passing from grade to grade without remediation of the fundamental learning problems, and equally important, with the stigma of failure. Unless struggling children are provided with social and remedial support, they may see school as an unpleasant burden, develop feelings of failure, and look for validation through non academic experiences. Social support helps children cope with the stress, and they are buoyed by interacting with healthy, interested, and caring adults. While support is an important element, children also need intervention that are specific to their learning disorder. Communication and language development. During middle childhood, children develop increasingly complex receptive and expressive language skills that are the result of continued brain maturation. Consider the difference in how a 6-year-old expresses themselves versus a conversational ability of a 10-year-old. Children language patterns provide insight into the neurologic development status. They have a well-developed vocabulary and retrieve words quickly. Their expressive language should be fully intelligible. Stuttering usually resolves during early childhood, but may still be present in early middle childhood, especially when children are overly eager to express themselves. Occasional or brief stuttering that does not cause distress is considered normal disfluency at this age. Looking at Table 12.2 provides a more detailed summary of the progression of language development in this period. Multilingualism is increasingly prevalent as societies continue to diversify. Multilingualism proficiency is reported to be associated with improved cognitive functioning performance, though this remains controversial. Children who are learning English as a second language may need additional support as they juggle learning a new language with their other academic competencies. The assessment of communication skills in multilingual children should consider their primary language abilities. This approach also applies to children who are deaf or hearing impaired and use sign language for communication. Communication disorders affect about 9% of children between the ages of 7 and 10. Speech and language impairment may interfere with daily functioning, including the ability to learn, communicate, and interact socially. Language delays related to hearing impairment are associated with a higher risk for emotional and behavioral difficulties during childhood and adolescence. The identification of language delays or issues should ideally occur in early childhood, but many are first identified only after the child is in school. Prompt referral for focused intervention and/or speech therapy is needed to maximize academic potential and success. Which brings us here to table 12.2, the progression of communication skills in the middle childhood. So you see the different age groups between 6 and 7, 8 and 9, and 10 through 12. Common developmental concerns in middle childhood. Chronic conditions that impact development may have already been identified by the time children enter school age, or developmental concerns, particularly those related to learning or the school environment, may emerge during this age period. Wide variations in growth and development necessitate evaluations occur in the context of the child's age, developmental trajectory, and peer and family functioning. Common developmental concerns during middle childhood include school adjustment, learning challenges, and school refusal. Which brings us to school adjustment. School entrance is based on a chronologic rather than developmental age and generally begins with kindergarten enrollment at 5 years old. However, the process for determining school readiness and preparing children for the transition takes place earlier. School participation requires the ability to perform self-care, interact with a variety of new people, act with a sense of responsibility, and separate emotionally from the family and home base. Likewise, families must be ready for school and be able to support the child to develop new routines and adjust to the school environment. Children must learn to adapt many of their former behaviors as they adjust to school life. Sleep schedules are often altered to accommodate earlier wake times. Such sleep routine changes may negatively impact learning mood and behavior. Learning to adjust to structured schedules for school attendance, family and household responsibilities, extracurricular activities, and homework demands are challenging for children and families. Children may choose to bring food or eat meals provided by the school, and thus experience increased independence over their dietary choices and eating habits. Elimination may be affected if the child is reluctant to use the school bathroom, especially for defecation. Self-regulation of attention, emotion, and behavior is an important predictor of school adjustment. The initial immersion in the academic learning environment is challenging for all children, but those who lack the necessary skills to meet school demands and expectations may experience maladjustment and early school failure. Children with maladjustment may demonstrate internalizing behaviors or externalizing behaviors, underachievement, and/or failure. Parents need to support their children as they adjust to school. Parents may have difficulty adapting to their children's increasing independence and worry about how to appropriately supervise and monitor them now that children spend more time outside the home. Some parents have ambivalent attitudes about their child's school and distrust the school's capacity to meet their children's educational needs, while others get involved with their children's academic and social development. The primary care visit is an optimal time to encourage relationship building with the school. PCPs have the responsibility to work with children, parents, and communities to promote optimal development for children and their families during the transition and adjustment to school. Table 12.3 will see details on history, physical exam, assessment, and planning related to school adjustment. Bringing us to the learning challenges. Learning challenges often present during this age especially as the child transitions to and progresses through school. Academic success requires the integration of information processing, memory formation, and recall, selective attention, expressive and receptive language processing, and beginning problem solving skills. Knowledge continually expands due to academic gains, experiences at home, activities with friends, and observations in the community. Self awareness is reflected by a child's ability to predict performance and emerges first in areas in which they have the most knowledge. Children with learning challenges may have difficulties with one or more areas of cognition, including information processing, language, attention, and organizational skills. Higher cognitive functions, such as memory and sensory function, motor capacities, visuospatial analysis, and neuromotor function, and social awareness and behavior. PCPs need to be alert to comorbid mental health and behavioral conditions, as they may occur in children with learning challenges. Dysfunction in sensory integration or processing may also interfere with learning. Children with sensory integration dysfunction may require classroom modification and assistance. Sensory integration can be particularly challenging for children with developmental or behavioral disorders such as autism spectrum disorder or ADHD. Early identification of learning challenges is important to ensure that children access resources to maximize their potential and facilitate academic success. The PCP must be alert to red flags that indicate school success may be at jeopardy, and they must be ready to intervene with families and school professionals to obtain necessary evaluations and resources to address these problems. Again, see Table 12.3 for the details on the history, physical exam, assessment, and planning related to learning challenges. Which brings us to the school refusal. School refusal is a term that was introduced in the 1970s to describe a phenomenon arising with a cluster of heterogeneous causes. The estimated prevalence of school refusal ranges from 1 to about 4% in middle childhood. School refusal is characterized by severe difficulty attending school, refusal to attend school, or severe emotional upset when attempting to go to school that occurs in the absence of significant antisocial disorders and involves staying at home with parental knowledge. Children typically request to stay home from school for a variety of physical complaints, which may include stomach aches, headaches, dizziness, fatigue, or a combination of these. The symptoms gradually improve as the day progresses and often disappear on weekends. School refusal may occur at any age, though unexcused school absences peak during early adolescence, between age 11 through 13. It is important for providers to be aware that mental health disorders such as separation anxiety, social anxiety, or depression are common among children with school refusal. Again, that table 12.3 will detail that history, physical exam, assessment, and planning related to school refusal. Intervention is generally successful when behavioral measures are combined with supportive counseling for the entire family. In mild causes, school refusal can be managed in primary care. The PCP should evaluate somatic symptoms to rule out organic disease without excessive medical attention or diagnostic testing, which can reinforce the behavior. Additionally, the PCP should address environmental factors, which may include bullying or home stressors, through communication with the family and school, and include referral to community support services as needed. Once there is a plan in place to evaluate organic causes and address environmental contributors, children are encouraged to return to school. In many cases, once the aforementioned concerns are addressed, the child's symptoms resolve. Children with more severe presentations, such as those whose symptoms persist Despite intervention or screen positive for underlying psychosocial conditions, should be referred to a mental health specialist. They may benefit from further interventions such as cognitive behavior therapy, counseling, and medication. So, some health promotion topics in middle childhood. During middle childhood, parents and caregivers should provide opportunities for children to incorporate their emerging skills and abilities with family expectations and beliefs about health maintenance, such as nutrition, oral health, sleep, and safety. For children this age, assuming responsibility for their own health begins with simple goals and tasks, progressing to more complex decision making strategies with mastery. Starting off with nutrition, careful attention to nutrition is important, given that 36.5% of US children are considered overweight or obese. As children become more independent, their food choices and eating habits can significantly impact on their overall health. For example, the consumption of sugar-sweetened beverages, high-calorie snacks, and other high-calorie foods contribute to obesity in middle childhood. Nutritional monitoring is necessary throughout childhood, and early intervention must be provided when indicated. Choosing nutritious foods while away from home and learning to eat new foods are areas for learning. Children this age progress from simple to more complex nutritional responsibilities. The primary care provider should engage children and parents in discussions about their nutritional habits and provide guidance for healthy eating with a supportive and non-judgmental approach. The PCP also needs to investigate child statements suggestive of disorders, eating, or weight modification behaviors. Table 12.4 provides a list of anticipatory guidance for health promotion that is related to nutrition, bringing us to oral health. During this age period, children begin shedding their primary or baby teeth and their permanent or adult teeth erode. Oral hygiene, including brushing and flossing, is essential practice. Children assume increasing responsibility but should only be independent when they have sufficient manual dexterity to perform appropriate brushing and flossing. Even when children are independent, parents should ensure oral hygiene is completed twice daily and periodically ensure the child is using proper technique. Healthy habits to encourage include choosing water over sugar-sweetened beverages and juices and limiting candy and sticky gummy foods consumption. Additionally, to examining the teeth for caries or oral dental concerns, the PCP should obtain an oral health history, assessing for oral health risk factors. Understanding that the child's oral hygiene routine and ensure the child and family have a dental home. For children without a dental home, the PCP should provide resources or referrals as needed. In Chapter 20 provides more detailed information regarding oral health needs as well as its management. Table 12.4 provides a list of anticipatory guidance for health promotion that is related to oral health. Which brings us to Table 12.3, a good spot to hit pause so you can take a look at the developmental concerns in childhood. Here you'll see the history, physical exam, assessment, and planning. Sleep. Sleep is an important consideration as disrupted sleep negatively impacts a child's cognition, academic performance, emotional regulation, and other health outcomes, which include obesity. The American Academy of Sleep Medicine recommends children this age sleep between 9 and 12 hours per night without naps. Night terrors or sleepwalking, however, may occur, which will be discussed further in Chapter 16. PCPs should okay, we're going to go back up so we can hit pause in appropriate spots. Spot 1, school adjustment. Spot 2, learning challenges. I'll go down some so that it's as much as possible here. Spot 3, school refusal. And as always, if I'm ever too quick, just hit pause. PCPs should assess for child sleep duration, quality, and hygiene, and explore problems related to falling or staying asleep. Parents can support healthy sleep habits by providing an environment conducive to uninterrupted sleep, including a dark sleep space without electronics, and encouraging a consistent and calming bedtime routine. Table 12.4 again will provide a list of anticipatory guidance for health promotion related to sleep. Bringing us to safety. Children this age enjoy increasing capabilities related to their continued physical development. They will often test rules and boundaries, which underscores the importance of safety considerations in this age group. To make safe choices, they need guidance and direction, as well as clear family expectations and associated consequences. Increasingly, peers and influences outside the family impact children's decision related to risk-taking behavior. The PCP has an important role in providing safety guidance to children as well as their families. Children typically outgrow car safety seats and transition to booster seats before middle childhood. However, they should remain in a booster seat as early as 8 years of age up to 12 years, depending on the child's height and state child restraint laws. During middle childhood, most children ride bicycles or other wheeled devices. Therefore, emphasis on consistent helmet usage and rules for riding safely are important. In middle childhood, a high proportion of children engage in organized sports and other extracurricular activities. Therefore, PCPs need to emphasize proper safety equipment use and adult supervision. Other safety considerations to highlight include crossing streets, sun protection, fire prevention and planning, and activation of emergency services. PCPs should assess safety within children's homes, neighborhoods, and schools. With the widespread accessibility of the internet and social media, online safety is also a growing concern in the age group. Families should be counseled on supervised internet use, internet safety tools, and restricted access. Access may expand with maturity and demonstrated responsibility. As firearms are a leading cause of death in children, PCPs must also promote firearm safety, which includes screening for firearms in the home and advising on safe firearm storage in the child's home as well as in homes they visit. Children need to be taught about stranger danger, inappropriate touching private parts, and the potential dangers associated with keeping secrets for and from others. Children who experience physical, emotional, or sexual abuse require immediate referral to Child Protective Services. Furthermore, bullying and ostracism have been shown to interfere with the development of academic performance. Therefore, the PCP needs to assess for bullying and, if suspected or confirmed, work with the family and school to ensure it is addressed. Again, Table 12.4 will provide a list of anticipatory guidance for health promotion related to safety. So here's Table 12.4, the anticipatory guidance topics in middle childhood. Again, we'll go over nutrition, oral health, sleep, and safety. A good spot to hit pause. Which brings us to health supervision visits. Middle childhood health supervision, the preventative visits, occur annually. PCPs can best assist children and families during these visits by reviewing the child's progress, validating parent efforts, and providing education and guidance. Every health supervision visit should include a history, a physical exam, developmental surveillance, and anticipatory guidance. Bringing us to the history aspect. The health history includes a comprehensive summary of the child's physical, nutritional, neurodevelopmental, psychosocial, behavioral, and emotional status. The visit should begin by building rapport with the child and parent caregiver. During middle childhood, direct questions first to the child, including aspects of daily routines, family experiences, school activities, and status, socialization, and any concerns. Invite parents to confirm or expand on the data collected and to provide additional information. In pediatrics, family system assessment is crucial. It is particularly important to evaluate how well the family is nurturing the child while supporting the child's effort to become more independent and create a unique sense of self. The PCP should strive to integrate the health history with anticipatory guidance by eliciting information about a topic and providing education and resources within the same discussion, which will be discussed more in Table 12.5. Box 12.1 provides a list of topics to address during an annual health supervision visit in the middle childhood. The physical exam. Physical examination includes a comprehensive assessment of all body systems, including growth and sexual maturity. It's also an opportunity for the PCP to elicit child and parent questions or concerns about body changes, and to provide education and anticipatory guidance about physical growth and pubertal development. Engaging the parent and child during the examination is important and can be achieved by providing a verbal summary of findings as the examination progresses, with emphasis on expected findings. The PCP should incorporate a developmental assessment within the context of examination and note any physical manifestation pointing to delayed or asynchronous development. Findings that are typical should be explored further. Again, in box 12.2 contains information about common conditions that should be screened during the physical examination in middle childhood. So we're going to go up here and we'll take a look at Table 12.5, Health Supervision Visits, the History, Physical Exam, and Anticipatory Guidance, going through growth and development, gross and fine motor development, social development, and again, hit pause as needed. Try to make sure I get as much of it in one spot as possible. Here it's talking about the emotional development as well as the cognitive development. And lastly, the communication and language development. It also hits here box 12.1 and 12.2, topics for the health supervision visit, as well as the common physical conditions in middle childhood. Which brings us to screening. Formal screening in middle childhood may include questionnaires, laboratory analysis, and other testing. Universal annual surveillance of developmental, overall psychosocial functioning, and body mass index are important. Table 12.6 provides a summary of health screening recommendations in middle childhood. Selective screening may also be performed in children with specific risk factors or health concerns. Developmental and psychosocial screening tools may be used to facilitate the child, parents, and teachers to provide specific information about a child's development, behaviors, and emotional status. Growth and development surveillance is an essential aspect of the visit history because visits occur less frequently than in earlier childhood, and much can change from year to year. Surveillance does not entail formalized screening tools, but rather monitoring of growth and development. The PCP should follow up on any concerns raised related to physical growth and motor, social emotional, cognitive, or language development. If concerns arise, it is useful to elicit a parent, teacher, and child perception about the specific issue, as perspectives can vary across environments. Bringing us to the anticipatory guidance. The provision of age-appropriate anticipatory guidance should be directed at children and parents because children are increasingly responsible for self-care as they begin to mature. Table 12.5 includes anticipatory guidance topics that are not intended to be exhaustive, but rather to illustrate how these concepts can be applied to everyday living. Parents typically welcome PCP suggestions and resources that help them understand, respond to, and support various aspects of their child's behavior and development. So here is Table 12.6, the recommended health screenings during the middle childhood. Things to look for such as anemia, blood pressure, body mass index, development, dyslipidemia, lead toxicity, oral health, psychosocial behavior, sexually transmitted infections, tuberculosis, vision, and hearing. And then it brings us to table 12.7, the developmental behavioral screening tools for the middle childhood. Again, a good spot to hit pause to review. Which brings us to the last section here, developmental red flags for middle childhood. Children this age may present with serious problems, which table 12.8 identifies the red flags during middle childhood. PCPs must be alert for indications of more serious concerns and, if needed, assess the child and family more thoroughly. PCPs can address risk factors and provide guidance on prevention of health concerns. In situations where the child is referred to subspecialty care, the PCP has a crucial role in serving as a medical home and collaborating with subspecialty professionals to ensure children and families receive timely, appropriate, and coordinated services. Which leads us to Table 12.8, Developmental Red Flags in Middle Childhood. When it comes to the motor skills, cognition and perception, communication skills, social and emotional skills. As always, we'll review some of the references, but that concludes the chapter here. As always, I thank you for listening, and I'll see you at the next chapter. Till then, thank you, and goodbye.